had raised in CA125, which was raised at 353, and she underwent another imaging with PET-CT scan, which showed peritoneal carcinomatosis in the pelvis and low volume ascites. The platinum-free interval at this time was 37 months. Here we can see the pictures of the PET-CT scan showing the carcinomatosis at the pelvic level. So we can discuss now what is the appropriate treatment of a BRCA mutated recurrent high-grade serous ovarian cancer patient after the treatment with PARP inhibitors. Our patient underwent a further debulking surgery with laparotomy and a cytoreductive surgery including pelvic peritonectomy, bilateral diaphragmatic stripping, splenectomy, Morrison's pouch peritonectomy, large bowel resection with end-to-end anastomosis, ileal resection with lateral anastomosis, and loop ileostomy formation. She had no residual tumor at the end of the surgery, and she underwent also HIPEC, hyperthermic intraperitoneal chemotherapy. The postoperative course was complicated by a grade B pancreatic fistula, which was managed by antibiotics and the drainage of the splenic fat collection. Histology showed again a recurrent high-grade serous ovarian cancer. And again, we can see here histology from the peritoneal nodule, which Professor Zannoni can comment again.
You can see a lot of cells without a fibrotic reaction that we are waiting for after chemotherapy. Unfortunately, these tumors doesn't respond very well. You see here a lot of glands and also solid area, some bodies around. The nucleus is high grade. In this case, sometimes you can observe also clear cell cytoplasm that you can confuse with cell carcinoma. But look at the nucleus. The nuclei are clearly high grade, large, hyperchromatic, typically of high-grade serous carcinoma. Another time again, a few mitosis, for the reason I explained before. The chemotherapy reduced the number of mitotic activity.
Many thanks, Professor Zannoni. So now we have the discussion about what is the role of HIPEC in recurrent high-grade serous ovarian cancer, but also what chemotherapy regimen we could use in recurrent high-grade serous ovarian carcinomatosis after PARP inhibitors. Our patient underwent 4 cycles of carboplatin and gemcitabine, which were undertaken between May and July 2017. After that, she had access, and she was one of the few patients in Italy to have access to, as an expanded access program, to niraparib 300 milligrams per day, and this was started after the chemotherapy. She had to reduce the dose of niraparib from 300 to 200 milligrams per day as she underwent hematologic toxicity. In March 2020, so a few months ago, the patient had another increase in the levels of CA125, which was raised at 47.5, and a PET-CT scan showed 2 isolated peritoneal nodules at the lesser gastric curvature and at the descending large bowel. The platinum-free interval was 33 months. So she underwent treatment which consisted in debulking surgery with laparotomy and cytoreduction with removal of disease at lesser gastric curvature, transverse mesocolon, left paracolic gutter. There was no residual disease at the end of the surgery, and the postoperative course was uncomplicated. Histology showed recurrent high-grade serous ovarian cancer, and here you can see the molecular pattern of the tumor. But we could ask Professor Zannoni to comment on this histology.
at the tumors composed of cells, there is a few fibrosis. Generally, after chemotherapy, we observe a lot of fibrosis. Probably fibrosis represents a good prognostic factor. But in this case, all the nodule is composed of tumor cells. Look at also here the fat of the omentum, and now some mitotic figures appear like that and like this. And finally, Ki67 is very high, 80%, and generally after chemotherapy, Ki67 is low, but in this case, the activity, the proliferative activity is very high. And this is the reason why Ki67 is 80%. So we have in recurrence, by recurrence, the tumors become worse.
Again, thank you very much, Professor Zannoni. And I'm wondering whether you want to give us a comment on the histology changes throughout the years as the recurrence were happening to these patients.
Look at here in the first diagnosis, the tumor is conventional high-grade ovarian carcinoma. There are a few lymphocytes. In the first recurrence, the most important feature is the clear of synapse. In the second recurrence, sometimes you can see fibrosis, but unfortunately, the epithelial cells are in a large number. Also observe some anomalies. But in the third recurrence, the idea is worse, and some mitotic figures appear like that.
Hello,
Okay.
Nicolo. Really quickly, I apologize to interrupt, but we're getting a little bit of background noise. Professor Coelho and anyone else of our panelists that have joined through the telephone, please remember to mute your phones so that Nicolo and Professor Zannoni sound very clear on the audio. Thank you. Back to you, Nicolo.
Thank you, Jess. I'm wondering, Professor Zannoni, if there is any worsening in the aspect of these nuclei and the cells throughout the years. Looks like the looks are more dark during at the last recurrence, or is just my impression as I'm not an expert?
No, you're right. I agree with you. There is a worseness of the tumors year by year. You get here in the third recurrence, mitosis appear, the nuclei are larger and more hyperchromatic.
Thank you very much. That's very interesting. So we could wonder what is the appropriate treatment of a recurrent BRCA mutated high-grade serous ovarian cancer after 2 PARP inhibitors treatment and cytoreductive surgery to no residual disease. Our patient also underwent the test Foundation 1, which is here highlighted, and which confirmed the BRCA1 mutation, and also the panels of the possible treatment that are suggested for that mutations. So I would like to summarize this case, who was firstly diagnosed in 2011 and went primary debulking surgery with adjuvant chemotherapy and maintenance bevacizumab. First recurrence, which was treated with chemotherapy only and olaparib maintenance treatment. A second recurrence was treated with surgery with HIPEC and adjuvant chemotherapy, followed by maintenance niraparib. And the last recurrence, the third one, which was treated with surgery, and we'll see how will be managed after that. We would like to remind all the audience to chat us your questions and comments as we are ready to reply. In the meantime, I would like to ask Natalia Rodriguez if she wants to help us with the discussion and lecture about all what we said in the case.
Thank you, Nicola. Good evening, everyone. It's a pleasure to present the lecture today with the Gemelli Hospital. So, 1 minute, yeah, that's okay. So, well, in this presentation, we are going to review all these controversial points, like the appropriate chemo for platinum-sensitive ovarian cancer, the role of HIPEC, among others. So first of all, as we know, epithelial ovarian cancer is the 8th most common cancer among women. However, it is the 5th leading cause of death. According to global estimates, 225,000 new cases are detected each year, and 140% women annually die from the disease. The upfront treatment relies on the bulking surgery to non-residual disease and platinum-based chemotherapy.
Sorry, Natalia, sorry, we can't see your presentation.
Oh, really?
Yeah. Please share your screen.
Yeah, I already done it. So, yes, could you please help me? Okay, here we go.
Yes, you should be. There you go, Natalia. Thank you.
Now you can. Okay.
Yeah, everything is good right now. Thanks.
Okay, so you want me to repeat these slides? Yeah. Okay. So I'm gonna review all these controversial points from the case that Nicola presented. Okay. So this is already okay. Well, as I said before, the upfront treatment relies on the bulking surgery to non-residual disease and platinum-based chemotherapy with the addition of anti-angiogenic agents in patients who have suboptimally debulked and stage 4. Moreover, major improvement in maintenance therapy has been seen by incorporating the PARP inhibitors, which have been approved in a recurrent setting, recently in a first-line setting among women with BRCA mutation. In the case presented, the primary treatment was primary cytoreduction, platinum-based chemo, and bevacizumab. The introduction of bevacizumab to the standard chemotherapy with platinum and maintenance therapy up to 15 months have shown an improvement of the progression-free survival. The likelihood of relapse depends on many factors: distribution of the disease at diagnosis, success of initial surgical cytoreduction, rapidity of the CA-125 resolution, and treatment response after primary therapy. The prognosis and relapse is mainly dominated by chemosensitivity of the tumor. The choice of a second-line chemotherapy depends on several factors. As you see here, depends on the platinum-free interval, persistent side effects, and toxicity profile. Until now, the platinum-free interval has been considered a main factor that guides the treatment choice at time of the recurrence. To consider a patient as platinum sensitive, the relapse has to be occurred more than 6 months later from the last dose of platinum-based chemo. In the case that Nicola presented, the recurrence was at 16 months from the last dose of platinum. So for that, we consider this patient as a fully sensitive. This is from our ESGO guidelines. In the recurrence of ovarian cancer, if a patient is platinum sensitive, the standard treatment is still represented by systemic therapy based on carboplatin-based combination chemotherapy. So, well, we're going to develop theory for recurrence ovarian cancer. Here it is the DEXTO-3. In this prospective randomized multicenter study, patients with ovarian cancer and first relapse after 6 months of platinum-free interval were eligible if they presented with ESGO score positive and were randomized to a second-line chemotherapy alone versus cytoreduction surgery followed by chemo. A total of 407 patients were included, and in both groups, almost 90% of patients received platinum-containing second-line chemotherapy. As you see here, the median PFS was 18 and 4 months with surgery and 14 months without surgery. Indeed, patients undergoing surgery saw a prolonged PFS compared with patients undergoing chemotherapy alone. Regarding the primary outcome, the median overall survival in the intent to treat population was 53 and 7 months with and 46 months without surgery. In conclusion, the ESGO-3 is the first prospective randomized trial showing an overall survival benefit of the bulking surgery in recurrent ovarian cancer. Therefore, the overall survival benefit was highest and seen in the cohort with complete resection, indicating the chance of the selection of the right patient and the enter of HIPEC. As far as we know, the addition of HIPEC to interval cytoreduction surgery improves the recurrence-free and overall survival in patients with stage 3 ovarian cancer who are ineligible for primary cytoreduction surgery. Here you see the OB-HIPEC-2 study, an international randomized open-label phase 3 trial to evaluate the effect of HIPEC on overall survival in patients with stage 3 epithelial ovarian cancer who are treated with primary cytoreduction surgery, resulting in no residual disease. This study will enroll 538 patients randomized in a 1-to-1 ratio to receive HIPEC or no HIPEC. All patients will receive 6 cycles of platinum-paclitaxel chemotherapy and for inhibitors of the estimated are going to be anticipated in 2026. So we will have to wait for a while. The current evidence that we have about HIPEC comes from Vandriel study, a multi-center open-label phase 3 trial randomized in 245 patients who had at least stable disease after 3 cycles of carboplatin to undergo interval cytoreduction surgery either with or without the administration of HIPEC with cisplatin. 3 additional cycles of carboplatin and paclitaxel were administered for surgery. A total of 110 patients underwent cytoreduction surgery without HIPEC. 39 patients underwent cytoreduction surgery with HIPEC. The median recurrence-free survival was 10 and 7 months in the surgery group and 14 and 2 months in the surgery plus HIPEC group. The median overall survival was 33 and 9 months in the surgery group and 45 and 7 months in the surgery plus HIPEC group. The conclusions are that the addition of HIPEC to interval cytoreduction surgery show a recurrence-free survival and overall survival than surgery alone. However, this study was highly criticized for several reasons. First, the recruitment period was long. The complete cytoreduction was reached in the 70% of patients. The primary endpoint was not overall survival. There was no information provided about the surgery's quality. No information about the side effects was provided. Well, what about the HIPEC in the secondary cytoreduction surgery? In this study by Sivanovic, patients were randomized to carboplatin HIPEC or no HIPEC. The HIPEC group received 5 additional cycles, and the standard group received 6 postoperative cycles of IV platinum-based chemo without maintenance treatment. A total of 49 patients were randomized to the HIPEC group, and complete broad secondary cytoreduction surgery was achieved in 84% of the standard group and in 82% of the HIPEC group. There was no preoperative mortality and no significant differences in the median PFS or median overall survival between the groups. The conclusions are that the secondary cytoreduction surgery with carboplatin HIPEC followed by 5 cycles of platinum-based chemo was not superior to secondary cytoreduction surgery without HIPEC followed by 6 cycles of platinum-based chemotherapy. Indeed, further research will be needed to elucidate the role of HIPEC in the secondary cytoreduction area. So basically, the ESGO guidelines recommendations for first-line treatment are that HIPEC is not a standard of care with a level of evidence to. Regarding the maintenance therapy, we have 2 important studies with the participants. The first one is regarding olaparib as a maintenance treatment. This is an international randomized phase 3 trial to evaluate the efficacy of olaparib as maintenance therapy in patients with newly diagnosed advanced ovarian cancer, stage 3 and stage 4, a mutation in BRCA1, 2, or both, who had a complete or partial clinical response after platinum-based chemo. The patients were randomized in a 2-to-1 ratio to receive olaparib or placebo. As you see here, a total of 381 patients underwent randomization, 260 were assigned to receive olaparib, and 131 to receive placebo. The conclusions from the study were that the use of maintenance therapy with olaparib provided a substantial benefit with regard to progression-free survival among women with newly diagnosed advanced ovarian cancer and BRCA1/2 mutation, with a 70% lower risk of disease progression of death with olaparib than with placebo. The second important study in the recurrent setting is this one. This international multicenter randomized phase 3 trial evaluated olaparib tablet maintenance treatment in platinum-sensitive relapsed ovarian cancer patients with BRCA1 or 2 mutation who had received at least 2 lines of previous chemotherapy. A total of 285 patients were randomized to receive olaparib or placebo. So the conclusions from this study were that olaparib tablet maintenance treatment provided a significant progression-free survival improvement with no detrimental effect on quality of life in patients with platinum-sensitive relapsed ovarian cancer and BRCA mutations. Continuing with the PARP inhibitors, in this randomized phase 3 trial, patients with newly diagnosed advanced ovarian cancer were randomized in a 2-to-1 ratio to receive niraparib or placebo once daily after a response to platinum-based chemo. The primary endpoint was the PFS. Of the 733 patients who underwent randomization, 373 had tumors with homologous recombination deficiency. Among these patients in this category, the median PFS was longer in the niraparib group than in the placebo group, 21 and 9 months versus 10 and 4 months. The conclusion is here. Among patients with newly diagnosed advanced ovarian cancer who had a response to platinum-based chemo, those who received niraparib had a longer PFS than those who received placebo. What about niraparib current setting? This trial tried to evaluate the efficacy of niraparib versus placebo as maintenance treatment for patients with platinum-sensitive in recurrent ovarian cancer. In this randomized double-blind phase 3 trial, patients were categorized according to the presence or absence of the BRCA mutation and were randomized in a 2-to-1 ratio to receive niraparib or placebo. The primary endpoint was the PFS. Of 553 enrolled patients, 203 were in the BRCA group and 350 patients were in the no BRCA group. Patients in the niraparib group had a longer median duration of progression-free survival than did those in the placebo group, including 21 versus 5 and 5 months in the BRCA group. Well, the conclusions from this study are that among patients with platinum-sensitive recurrent ovarian cancer, the median duration of progression-free survival was longer among those receiving niraparib than among those receiving placebo, regardless of the mutation of the BRCA mutation status, with moderate bone marrow toxicity. So this is the current evidence that we have until here. And for the last recurrence, what do you recommend? It should be retreat with chemotherapy. Would you recommend PARP inhibitors? So I would like to open the discussion with these questions for the senior panelists. So that's all about my presentation. Lastly, I would like to thank the ENIGO and especially Soya, Andrea, and Nicolo for all the help. Thank you so much for your attention.
Thank you very much, Natalia. Thank you very much, Nicola, for this interesting presentation. And thank you very much, Natalia, for so instructive, didactic lecture. So I just want to remind that we have an opportunity to, you can text your question to us, and senior panelists will answer after discussion. So we go forward, and I would like to ask Professor to make some comments.
Sorry, did you ask me? I didn't get it. Yeah.
Okay, go ahead, Professor Colombo.
No, because you said professor. I didn't get which professor, so I didn't know if you were asking me or.
So Professor Colombo, please go ahead. Please, your comments.
Yeah. Okay. So this is a very interesting case. I think is a typical BRCA mutated patient because she has such a long history and. She has repeated responses to platinum compounds, very long-lasting. So it's really very emblematic, I think, in this respect. What is I don't want to comment on HIPEC because I have my view, which is probably not really online with what was said. But anyhow, so in terms of chemotherapy, I think it was absolutely correct to repeat platinum because she always responded. And what it is unusual here is that she received, possibly, we don't know, I think, twice the PARP inhibitors because she participated in the solo study. So it was placebo versus olaparib. So I don't know if you asked for the unblinding of these patients or not. Did you? Did you know if
yes,
she
received olaparib? Yes, we did, actually. Yes, we did, and she received olaparib.
Okay, so this is an unusual situation because we don't have so far any evidence that you can have the same level of activity if you repeat the PARP inhibitors twice or even more. So far, there is, as you know, an ongoing study which is the OREO study and is looking at the retreatment with PARP inhibitor. But so far, we don't know if this is the case. She had probably a benefit because she has already a very long interval before and she had another very long interval after that. But we don't know. This could be the case even without niraparib. We are not sure about that, but for sure because she has a BRCA mutation. So what to do now? I think I don't quite understand your brackets with niraparib because this is the last thing I would do. she had already twice the PARP inhibitors and actually. I know that niraparib is approved in USA in patients with platinum-sensitive disease and HRT positive as a treatment, not as a maintenance, but we don't have this opportunity in Italy for sure, and in Europe. We have rucaparib, in fact, for patients with BRCA mutation, but without prior treatment with PARP inhibitors. So I really don't see how we can use niraparib in this situation again. She is platinum sensitive. The real question is, since now she is without disease after surgical cytoreduction, would you dare not to do anything and wait for the relapse? Or would you treat her with the standard treatment, which is platinum-based chemotherapy?
Yes, thank you very much. Thank you very much. Professor Anna Fogori, please, could you comment?
Yes. First, thank you very much for this comment, Professor Colombo, because it's very interesting to get information from different sites, because it's really a challenge to find treatment in these patients who received so many treatments. Yes, the first point is that the patient received niraparib after olaparib because she entered into the expanded process, which was opened only for few days or few weeks and then was closed. So she entered in the program and then the program was closed. And this is the reason why she had the opportunity to have a second chance with the PARP inhibitor. I like very much the comments from Gianfranco, highlighting how the tumor changes after different treatments, and especially the fact that the tumor has a different changes if she received only standard chemotherapy or any kind of PARP inhibitors. So it seems that after PARP inhibitors, the effect on histology are different. There is no more mitosis, there is a high level of mitosis and there is less fibrosis. So I think it's interesting that if we use some kind of biological drug, the effect on the tumor are different. And regarding the last point, what to do now? Yes, we had a long discussion at our own tumor board, and we discussed all the options. I would like to ask you, if you consider the chance to continue niraparib, it's not like another line, it's just like removing those clones who are possibly resistant and continue with maintenance because it seems effective. At the end, she had only 3 nodules in the abdomen, and that's it. So I know that there are some protocols that probably are coming out, and there are some retrospective studies evaluating this type of option. And I was wondering if you agree or not on this. And the last point is that we had several repeated surgeries, even though one of them was with IPEC within our internal protocol. But however, she had different surgeries. So this is another matter of discussion, how many surgeries we can do. And I think it's also interesting that at the first recurrence, she was not resectable and she had BEV, whereas she was resectable twice after PARP inhibitors. So maybe the disease changes according to the type of treatment the patient she received. Thank you.
Yeah, if I can answer to the niraparib continuation, yes, definitely. This is something that we also do. If you have a local regional relapse during the treatment with PARP inhibitors, we definitely consider local regional treatment. Most of the time we do radiotherapy instead of surgery, but it's the same concept. And then we keep going with the PARP inhibitors. This for sure, because as you said, the concept is that you may have clones which are maybe resistant to PARP inhibitors. This does not mean that overall PARP inhibitors are not effective anymore. So yes, for sure, this in fact is a good option. So not to start a new treatment, but just to carry on in the same way. This is for sure something that I would consider.
Thank you. Christina.
Thank you very much. Thank you very much. I'm so sorry, Professor Portable. Have you got some comments?
connection. So what we have seen very often is exactly what Anna and Nicoletta said, that after PARP, very often the tumor dissemination patterns change. We have had here patients with liver and lung mets and inoperable peritoneal disease, had PARPs, and then everything went away, somehow like per magic. And then they only had like a pelvic mass, which we debulked, and then they continued PARPs. So we see that not uncommonly, and also many of us, I remember I was sitting in an Adford the other day, and then many of us commented on that PARP somehow changes the phase of the disease. So we can't say, oh, this was inoperable in the past. I mean, in the desktop study, the criteria are that if you have inoperable first disease, the AGO score is negative, so it doesn't really comply with the desktop. We have seen a change of this phase with the PARPs. And patients who would be perhaps inoperable, or patients who would be not usually considered for surgery, they now suddenly are operable with, so it's not, so we need to be very careful before dismissing somebody not to operate just because she was inoperable in the beginning with the PARPs. It's a very interesting observation. And then, as Nicoletta said, sometimes we, instead of giving chemo, we just continue the PARPs. Here in the UK, it's a very common PARPs. It's not really of any prospective randomized evidence, but it's many oncologists, at least here in the UK, they go that route. Alexander, we can't hear you.
Sorry. Thank you very much for your comments. Professor Kirillov, have you got some comments?
I have a question for the surgeons, Christina and Anna. We saw that in this tumor there is not fibrosis, but the nodules are completely composed of plastic epithelial cells. I'm asking if it is more difficult for you to remove a tissue, a very fibrotic tissue. So when in the tumor there are a lot of fibrosis, I think you can.
You can't. There isn't a specific rule. There isn't. There are some studies that even we did here in Imperial with the radiomics. I think Anna also has done radiomics in your institution, where we correlated the radiomic signature of a tumor with the fibrotic changes and then probability. There was some correlation, but you can't really just say. So if we had high stroma markers, these high stroma markers correlated with a poor RPV, with a lower RPV that correlated with more adverse prognosis, so that way. But at the end, the probability is a multi-factor situation from many things. The habits of the patient, where the tumor is, we can't just say, oh, it has fibrotic changes. That is more difficult to move. Anna, what do you think?
Yeah, I completely agree with you. First, I think, yes, maybe it's true that fibrosis is difficult to remove, but actually we don't need to remove fibrosis. We need to remove the cancer. So if it's only fibrosis, it's okay. It's fine. And the second point is that, as you said, Christina, it's interesting that location of recurrence after PARP inhibitors sometimes is completely unexpected. So yes, in this case, we had nodules in the abdomen, but why here? I mean, why in the less curvature of the stomach or on the spleen? But sometimes we have on the psoas muscles, very deep in the pelvis, close to the sacrum. So we actually, after PARP inhibitors, they see very strange locations. So again, it's the very many different factors together which affect the resection of the tumor itself.
Thank you very much. Denis, have you your opinion? Professor Kirillov, please, your opinion. can't hear.
Dennis?
Sorry, we can't hear. Okay, we have some trouble with audio, so maybe we can go to questions from audience, and we have interesting question regarding surgery. I think that this question is addressed to Professor Fagotti. What do you think if total peritonectomy have been added? This patient can benefit or no in the first set reduction?
I think that total peritonectomy is not really needed in ovarian cancer. We do only removal of tumor, macroscopic removal of tumors, so we never know what's behind the macroscopic removal, but there is no need to remove the peritoneum if it's not affected by the tumor. Otherwise, we should remove the entire bowel and everything that is in the abdomen. At least it is our school. The second question is the role of IPEC at time of primary site reductive surgery. There is a randomized trial that Natalia has just presented, and we will participate in it. So until we have the results of the trial, we can't do any conclusion, of course. So I don't know the answer, actually.
Thank you very much, Christina. Maybe you have some comments?
I completely agree. This term total peritonectomy is an illusion. You can't possibly remove the whole peritoneum here. Anna said you can't possibly remove the whole peritoneum of the whole abdomen. So we go with macroscopic what we see. So the macroscopic affected areas, they need to be removed, whether this is visceral or parietal peritoneum. And then we know that approximately after 8 to 10 days, there are islands of new cells of peritoneum that build in the gaps, and then they confluent together and build a new peritoneum. And that is why when we operate at relapse, we can do a second peritoneum. And that is why also the patient will always relapse, because only within studies. We have a study, if there is a study and we participate, fine. Otherwise, there is no prospective randomized benefit or strong evidence for hypercat.
Thank you. Thank you very much. We have an interesting question from audience regarding chemotherapy, and I think this question will address to Professor Colombo. So in first line of chemo, carboplatin was used in AUC 6 instead of 5 AUC. So it was 3 drugs in the first line of treatment, and audience asked, what about toxicity? And please, Professor Colombo, your opinion.
Okay, so first of all, depends on how you calculate AUC, because you can really calculate it or just estimate it. So you can use the formula, or you can really evaluate the glomerular filtrate. So AUC 5 can be similar to AUC 6, depending on what you use. Anyhow, I think we do have evidence that the AUC 5 and 6 are very similar. So you can use both. I don't think there will be any major differences by using AUC 6, and of course the toxicity will be higher. So you can also judge based on the general condition of the patient and how old she is and how she's fitting. Of course, this lady was young, so if you want to invest a lot, you may and she can tolerate, you may expect that she can tolerate well the chemotherapy, then you can go with HC6. It is true, however, that patients with BRCA mutations sometimes have problems with the hematological toxicity. Of course, they can tolerate less well. So you have to pay attention to these patients because sometimes they have heavy hematological toxicities.
Okay, thank you very much. And we have a question especially for Anna Pagbotti. Your opinion about using HIPEC initial surgery may have delayed recurrence.
Yes, I mean, this is a personal opinion, but it is also supported by the OVIPEC-1 trial that has been published 2 years ago now, and that has been presented by Natalia again. There is another ancillary study of this trial that I had the chance to review and which will be published in the International Journal Gynecological Cancer, where they reviewed all the CT scan from the trial with dedicated radiologists. And they actually found that this the group of in the HIPEC arm had a lower rate of recurrence in the peritoneum. So it may happen that HIPEC has a protective effect on peritoneal disease. This is, of course, just a comment coming from the results and ancillary results of this study, and we have to see if it will be confirmed for first-line treatment at time of primary surgery.
Thank you. Thank you very much. So, a question regarding using PARP inhibitor. What was your retinal change in the PARP? Change the PARP, like alloparip, europarip, and so on. I think this question will be addressed to Professor Colombo.
I'm not sure I got the question. So the question is about why did you change the PARP inhibitor?
Yeah, why PARP inhibitors was changed?
Oh, that was, I think, a very practical reason, because the only way when they started the expanded access for niraparib, they allowed also patients already treated. But then they said, no, it's not possible anymore, so we had to stop. But we had, like 1 month or two in which we could, and that's why we took advantage, and I think that was exactly what happened to this patient. You could not do olaparib again. You, according to the regulatory authority, you cannot administer twice the same PARP inhibitor unless it is inside a clinical trial.
Thank you very much. And we have one more question regarding peritonectomy. In case of IVS during Anna.
So it is very interesting, actually. When I was talking to Ignas Fagot a few years ago, he was telling me that when he did his study, he was any scar tissue, he would take it, send it does not appear cancerous and would involve, a bladder peritonectomy. So very easily done. Yes, I would do it. If it's scar tissue that appears probably normal and would involve a rectal resection and anastomosis to take it out, then I wouldn't. Yeah. So I would not do 3 bowel resections and anastomosis just for scar. For the pathologist to really see in 10 minutes whether this is scar tissue or fibrosis or infection or cancer. So we have to make clinical decision during the operation, depending on how extensive it is. Sometimes you open up and you see scar tissue everywhere. well, what do you want to do there? Do you want to take the whole small bowel out? This is why you did the neoadjuvant chemotherapy, so that you don't have to do a bowel resection if we want to go that route. So we need to be very careful to just go heroically and removing and doing bowel resections just because of a handful of some scar tissue. If it's around, if it's obviously malignant or if it's obviously scar and cancer, then of course we would remove. But that is one of the main issues and problems and challenges of interval debulking surgery, and that is why I think that despite the fact that we have higher complete tumor resection rates at neoadjuvant chemotherapy, these patients do not live longer, just because probably the definition of tumor residual disease after neoadjuvant chemotherapy is completely different to upfront. In upfront, you see what you get. Yeah, interval debulking, sometimes we say tumor free, and it's probably not tumor free.
Thank you for your comments. Anna, please.
I completely agree with Christina again. I would never take out the fibrotic tissue just because it's fibrosis and I don't know what it is. It depends where it is. And if I believe it might be cancer, then I would do everything. Otherwise, I would leave it there.
Thank you very much. We have a very interesting question to all panelists. This question is regarding prophylactic mastectomy for patient who is BRCA mutated. It's your experience.
Absolutely yes. And I think the patient was scheduled for mastectomy, bilateral mastectomy. I don't know if she had at the end or the story was so much complicated to have mastectomy. I don't remember exactly.
Yes, sorry. Yes, I didn't mention that just because we focused on the ovarian cancer, but the patient between the surgeries and between the chemotherapy treatments, she had bilateral mastectomy and with the prosthesis addition.
Still, we need to be very careful. I have here patient. We need to be very careful with the prophylactic mastectomies in a patient where her prognosis will be limited by ovarian cancer, not by the breast. So if you have a patient with already 3 relapses from ovarian cancer, no matter how good you operate and how many PARPs you give, the patient will at some point die of ovarian cancer. So to go into the of extensive. So there is a very nice paper that I read once that I don't remember where it was, where they did an economic analysis and analysis of all the pros and cons of the time point of mastectomy compared to the diagnosis of ovarian cancer. And they said that approximately after 4 or 5 years, depending on the age, you should consider that. The issue is that we have sometimes, I had a patient the other day who had ovarian cancer stage 4. Immediately after her surgery or like treatment, like a year later, she had she had bilateral mastectomies, expansion and reconstruction, had complications from that, had to recover a longer time, and then she relapsed of her ovarian cancer. So we need to always be careful in which time frame to put it into the whole journey of the patient. Because at the end, even if she gets a small breast cancer, a patient with 3 relapses of ovarian cancer, she won't die of the breast, she will die of ovarian cancer. So it's tricky.
Yeah, it's right. Maybe she had, I suppose she had surgery at the very beginning of her history, and this is why she had it.
Yeah.
Thank you. Lenny, please, your experience about prophylactic mastectomy in France for patients with BRCA mutated and ovarian cancer, diagnosed with ovarian cancer. Unfortunately, we still can't hear you.
Professor Coelho, have you joined us through the phone audio? Is your phone in front of you? There we go. Can you try again to speak? All right, so Professor Coelho, give me a thumbs up. Do you have your phone in front of you and on, or no? I'm sorry. Okay, Alexander, I apologize. We're going to continue to troubleshoot with Professor Carlo. Please carry on.
Okay, thank you. Thank you. And I would like to ask Natalia this question, your experience in Spain. So we can't hear. Please switch off your microphone or switch on your microphone. So Natalia?
Yeah, Natalia, you're looking for the white microphone with a red circle around it on your control panel. If you can click that red circle, you should see it turn green. All right, and Alexander, let's keep rolling. We'll keep troubleshooting here.
Okay, thank you very much. So I think that we asked all questions from audience. We answered for all questions from audience, and it's time for summarize today's presentation. Please, Professor Fagori, can you make some summarize?
Yes, I think that the summarize is as the introduction. I think it's very interesting how the story of this tumor is going to change, and especially we understand now at least why some of our patients are living so long, and probably the reason is the mutation. And so we need to face with a new disease. We need to know it more and more in depth, based on histological findings, molecular findings, and considering all the options we have from a therapeutic point of view, which include both surgery, radiotherapy, stereotactic radiotherapy, and PARP inhibitors or any other type of treatment. So I think it was a nice case to discuss all the options we have today for these patients, and I would like to thank everyone for this opportunity.
Thank you very much. And I would like to ask Professor Colombo about the new generation of PARP inhibitor and future of PARP inhibitor in treatment of ovarian cancer. What would you think? Is it our future or no?
Oh, yes, for sure. I think we are just at the beginning. I think the future will be on combination of PARP inhibitors with other drugs. And there are several rational combinations which have been already explored and will be further explored. We already have some good results and good data. And so what I see in the future, as I said, first we have to demonstrate whether you can retreat a patient again with PARP inhibitor with the same success, but particularly where to go towards new combination, not only with anti-angiogenic agents, and we have already very nice data on that, but also with PI3K inhibitors. There is a strong rationale, but also with other DDR drugs. So there is really a huge possibility for the future, and for possible combination, which are already explored inside prospective clinical trials. So I think it is a PARP inhibitors world indeed. So it will continue to be a PARP inhibitors world.
Yes, thank you very much. And question regarding surgery. Yes, in case if PARP inhibitor is a future, what about surgery? What do you think? The role of surgery of treatment of recurrent cancer? Professor Fotopoulos, please, could you please comment? Sorry?
Now I'm unmuted. Yeah. So I think what we have seen from the desktop study and from all the retrospective studies even that we have done and we will do, is that it's actually the combination effort that matters for those patients. We can't say, oh, just surgery is enough and just getting the patient tumor free. I think a combination effort of maximal site reduction, and systemic treatment incorporating PARPs for the patients who are eligible will bring the maximum benefit for those patients. There is no discussion that the desktop data can perhaps be implemented even for the second and the third relapse. That's what I think, that's what many people think. But even though I'm a passionate surgeon, I really do not believe that surgery enough is alone sufficient. And we need to combine it with adequate systemic treatment. What perhaps can be the future is what Nicoletta said before, that after complete cytoreductive surgery, that these patients do not get chemo again. Perhaps we have seen that in the trial with sejuanib and PARPs, but just go just PARPs or just any other targeted agent or clinical trial. That, yes, I think will come. Yeah, but it is it's a team effort of systemic treatment and surgical treatment. And this systemic treatment does not need to just be cytotoxic chemo. It can be PARPs, can be anything.
Okay, thank you very much. And Professor Curie, everything is okay? Is your audio right now?
Hopefully.
Oh, yes.
Hopefully. Okay, thank you.
We are very happy to return here.
Yeah. And thank you for the technical assistance. Something went wrong. That's okay. So are we now at the time of conclusion, or do you think that we will continue with discussion and questions, Alexander?
I think that every question is answered right now, and we can make conclusion. And please, Professor Clay, you make the most valuable conclusion of this presentation.
But you still have to present all the slides before concluding. Otherwise, about this case, while you are thinking about the rest, it's a fantastic example of what we can do now for these patients. Because if you look at the life of this patient is a nightmare. But she has experienced more than 3 to 5 years of three intervals, and it's really how we use the combination of modern surgery, of targeted surgery for recurrence, which is a new concept and which is extremely interesting concept. Also the combination of re-challenge to platinum therapy, of bevacizumab and of PARP inhibitors. And that's the way, and hopefully this patient will reach the 10-year the 10-year survival target next year, and that's what we can hope.
Thank you very much for the conclusion, and I absolutely agree with you that this case is amazing combination of surgery and chemotherapy, which show us different possibilities for patients with BRCA mutation. And Nicola, again, thank you very much for amazing presentation, and Natalia, thank you very much for such instructive didactic lecture. So thank you very much for all panelists for discussion.